Hello, hello, hello. How are you? How is everyone? All right, so this is where I do a little talking, just kind of gibberish a little bit. And you tell me if my mic sounds nice. Miss Mills said, "Hey, I'm sounding loud and clear. That's what I'm talking about. Welcome back, Chair Bear. I remember you." She said she's an alum. She's coming back she's feeling a bit nostalgic and she wants to come check us out. Thank you, thank you, thank you. Hello, Francois. All right, I want to just say hello to my team. Hello, Mr. Sandeep. He's in the chat. He's up here with me. Excuse me. And Ms. Mills. I see you, Miss Haley. And Star Wars girl, wait a minute, Miss Beth. And if I missed anyone, please let me know. And I'm shouting you out, Miss Lucky. And I'm just assuming you're a female, so please forgive me if I'm incorrect. But she's the first one here. That's right. You get a special shout out. But shout out to all of you. And let's get started. This is week 8. Yes, we are halfway finished. We're halfway through, right? And if this is your first time coming, the purpose of these classes is pretty much to guide you through your 8-week, or excuse me, your 16-week course. Our purpose is not really to instruct, right? We want to hold you accountable. We just kind of want to make sure you're where you need to be. We want to be more accessible to answer questions. We want to review what you should already know, and we want to give you tips on how to navigate your course. Even if it's on a syllabus, we still want to give you those tips. And also, we want to point out key guidelines. I see Zalma. Haven't seen you in a while. Welcome back. And yes, I do remember my students. I do. All right. So just want to tell you, this is not the AMCI MCDC course. So if you think this is it, it is not. We pretty much compile all of the YouTube videos and made a course. We had enough good stuff. We always said it could help you pass the medical coding exams. Now it's time for us to show and prove. All right. So just so you know, we meet every week on Thursday at 12 noon. If you are registered, you will get weekly email reminders. No, we're not trying to sell you anything. No, no, no. Now at the end of the year, we'll let you know when we have our biggest sale, but that's it. That's not how we do things. Want to remind you on Mondays, we have the Guideline Masteries classes on YouTube with Miss Haley. It's an overwhelming success. People are saying they love it. It's fun. So go if you have time, and it's in the evening too. Also, we have interactive medical terminology and anatomy, and that's in Discord. That's every Wednesday at 7 p.m. And the 2026 MCG ebook is available. And if you're looking for that hard copy, we will let you know as soon as it drops. Okay? All right, so Lucky said it's fun. What's fun, Lucky? Tell me what's fun. Also, if you want to register for this class, it's your first time here, just go to our website, www.amcicoding.com, click on the YouTube course. After you click it on, just, of course you should read. You need to know what you're getting into, right? And then come back up and click on that enrollment form, complete the enrollment form, then click on the syllabus. Download your syllabus. Follow the syllabus in order. And that's it. Now, if you want to be guided and follow with us on Thursdays, on your syllabus, we have the RSVP, the class RSVP links, and it looks like this. All right, so this is week 8, and then 9 through 16, we're going to get started on a different code set. All right, so you just essentially click the link and RSVP. And my advice, click them all at one time. Just click them. Boom, boom, boom. And then after you click it, you'll come to the screen. It may look like this, or it'll have the emblem that you see for this class. But nonetheless, you'll come to your screen, click on that notify me, and it will notify you when class starts. And also, I don't know if you can see this at the bottom too. Don't forget to click that button too, so you're notified when we make uploads and all other good things. And somebody said, and thank you, Miss Star Wars Girl, she said, hey, now that you're in here, go ahead and click the like up button. So if you're looking at your computer screen, can you just click that like up button? The more people know, the better. All right. Now, textbooks. You can find information on the textbooks here. And just want to point out that you'll need the ICD 10CM. We do use Optum. We don't get any fee or anything from Optum. The only thing that we get from Optum is a discount for our students. And we're also giving you that discount too. So when you log in, you can click on the link to purchase Optum. Use our code. This is the AMCI special code, AMCI 2026, and you can get up to 50% off. I just purchased a PCS manual. I got 50% off. So definitely, because you are in this course, you are an AMCI student and you can take advantage of that discount. So that's all you need for this class. Now, Discord. Discord is where you can find some additional things. You can find additional study sheets, and the instructors are there. They're there to help you out if you have questions. They're there every single day. The interns are there, and you can build a community in there. So we definitely encourage you to join Discord, and you can follow the instructions from your syllabus. Also, this vital source, if you have any ebook, that's any ebook, if you have the Bucks ebook or anything, you can make your book, turn your book into flashcards. So this is the 2025 MCG. Just click on it, open it up. Here are some are these FTRs? No, these aren't FTRs. This is our TAP, but these are guidelines, right? So if you just want to make these make sense to you, you can personalize them anyway. So let's say you want to get this information, you want to make this a question. So you just highlight whatever you want your question to be. Automatically, you'll see this drop down. It'll populate like this. You click on Flash, create flashcards. Click it, then you paste it. This right side panel will open up, paste it in that panel, then highlight the back, what you want on the back. So let's say we want this part on the back. Then we'll copy it and paste it on the back, and then we'll click on study, or we'll click save first, then study. And once you're ready to study, you're going to have your own personalized flashcards. So this is how you'll do it if you have the MCG. You can do it with almost any book in Vital Source. So we encourage you to do that. All right, it's time to just kind of discuss where you should be. All right, so we're looking first from the perspective of our gold students. So YouTube gold students who purchased the online LMS, you should have completed all of week 8, all of it. Okay. Now remember, this is not the MCDC course. People think so because they have an LMS, but it isn't. So it's primarily the YouTube lectures, and it is some quizzes. We do put quizzes in there so they get more practice. All right. This is not the MCG. Let's go back. I'm going backwards. All right, so this is not our MCDC course. This, we always compare the two, and the things I want to point out that's big difference. Most of the content for this course comes from YouTube videos. The MCDC, there's about 85% private lectures. So we really do go in, and the MCDC prepares you for the CPC, CCSP, and CCS, and they have more access to your instructors. You know what I mean? And they can attend more private classes. And that is the cost. Yes, it is expensive. That's the going rate for most courses. And, some people, find value in it and they can afford it. But we know most people can't, right? I can't, not right now. So, if you want to, I do apologize. Let me go back. If you want like some of those private lectures, go here where it says a la carte. Sorry, it's on YouTube. click on the a la carte. Go to our website, www.amcicoding.com, click on a la carte courses, and you can get our private lectures. So, part one is Introduction to Medical Coding, but it's an expanded introduction. So, we give you step by step on how to code all of the, that's doing that on its own. I'm not even touching it. On how to code all of the CPT um, sections from from where do we start? Well, we actually start on with INTAG, but all of the surgery parts of CPT, E&M, all of it. So all of the introduction here, this is where we, kind of walk you in part one. Part two is advanced ICD-10-CM. Part three, that's advanced CPT. So it is economical. It's $59.99 a month. And when you're done, you're done. There's no contracts. And then we've got parts four for exam prep. If you want to prep for the CCSP, there you go. CPC, there you go. And even if you want to prep for the CCS, um, it is there as well. It's just not on the screen. This is a great complement to the free course, and you get the inside stuff. You don't get all the perks that the AMCI students get, and there are a lot. But I'm not here to sell it, so I'm not telling you the perks, okay? Now let's talk about the syllabus. The majority of us have the syllabus, and this is what we should have completed during or for this class. This is week 8. You are told to get the PowerPoint. The PowerPoint is in Discord if you want that. And then you can watch the playback from, we're saying Monday's class. Watch that playback. It's not from this session, it's from previous. Definitely watch it. It's really good. Then you're directed to read the official ICD-10-CM guidelines. This is from CMS. Click it, you'll see the actual PDF document. Also, if you have the MCG, and only if you can purchase it here, but also you're directed to read the guidelines for chapters 18 through 21 or 22. Then you've got a reading assignment, and that's in your Carol Buck's manual, Unit 2, Chapter 7. And then we gave you some additional lectures to watch. Click on that green button, that green click here. And there are additional exercises in Discord. All right. Now, if you have the LMS, you don't have to do anything. You don't even have to look at this. Everything has been placed in your LMS. And just want to let you know that playbacks are on this playback list. And don't forget to come back to your syllabus. It's easy to just work the playlist, and you really need to come back here because you can see all the valuable content and assignments. Now let's go ahead and click on that playlist, and it looks like this. They're basically lectures in the order that you should take them. All right, so Kay says she loves her MCDC course. Thank you, Kay. That's what I'm talking about. All right, so if you want to look at these playbacks, they will have this green and purplish color, and that's the playback from these classes. So if you missed any, just go and follow in order, and they should be there. All right, I tried to get this. I tried to correct this, so please forgive me. Hang tight. I wonder, I apologize. I did update it. I don't know why it's not on there. Am I on this interns? Okay. Nonetheless, for week 8, you should have completed chapters 18 through 22. You should know those specific coding guidelines for chapters 18 through 22. Those those specific coding guidelines for those illnesses and diseases that have guidelines. You shouldn't know them all. You should just know that there are guidelines associated. Also, you should still be mindful to apply general coding guidelines if applicable. And you should still have your head wrapped around other chapters' guidelines when it's applicable. And we do have an example of that today. So, without further ado, let's go ahead and test your knowledge. Let's see what you already know. And, excuse me, I have a little tickle in my throat. Um, since we have 4 chapters that we're going to be reviewing, I'm going to go ahead and place the chapter at the top so that you know where to search for the guidelines if you need to. All right, true or false? It's chapter 18. A symptom code from chapter 18 should be reported when the provider has established a definitive diagnosis explaining that symptom, unless the guideline instructs otherwise. True or false? I apologize. You heard me clearing my throat, or you may have. Someone asked if this is being recorded. It is. The link that you used to access this class, you'll see the playback, and it's also on playback. Okay, coders, what say you? We only got a few people answering. Go ahead, take that leap of faith and just answer. What do you think it is? No judgment here. We will never do that. We were in your shoes, every single one of us. All right. So the answer is false. It's false because a symptom code from chapter 18 should not be reported when the provider has established a definitive diagnosis. So maybe, I mean, that's like a basic guideline that we're going to drive home today. All right. So if you didn't know it, you will today. All right. Chapter 19. We're going to have a question from chapter 19. True or false? When coding a fracture in chapter 19, that 7th character A is used only for the patient's first visit for that provider. True or false? Okay, I am going to move right along, okay? Yeah, that's right. Give it a shot. Okay, so chapter 19 codes, you have to put that 7th character extender on it. And that A doesn't mean visit, it is for the initial treatment, that initial treatment phase. If someone breaks their arm and that arm has to be reset, and let's say it's going to be a few days before they can get that arm reset, they're still in the initial treatment phase. All right. So that's false. It's not the visit, it's the treatment. All right. True or false? We're still in chapter 19. For a traumatic injury, external causes codes or cause codes from chapter 20 are mandatory for all payers and must always be sequenced first. True or false? What say you? All right. I respect everyone that's answering. Even if you don't know, what is your gut telling you? If you don't know, just put what your gut answer is. All right. So great job. Look at that. DC Kicks. She said it. Also, I'm just assuming it's a woman, so I do apologize if I'm misgendering you. All right. So just Janet, that's what I'm talking about. Kathy, Patricia, Shenna, Hot Tub, Daisy. Well done, well done, well done. The answer is false. And let me give you a little tip. When taking most exams, including the medical coding exam, whenever you see the word all, always, or never, those are clues that it could be false. It's highly probable it's false, right? What is always? What is never? Very few things are, right? I'm not saying it's always false. It's a high probability. Not always, because I'm going to contradict myself today. But it says must always be sequenced first. So it's a probability, high probability it's false, but not always. Got it? And you know what's going to supersede that? A guideline. Anyway, this is false because chapter 20 codes are always sequenced, second or tertiary. Look at me contradicting myself. Hopefully I didn't confuse anyone, but good job. You all knew that. Okay, we're still in chapter 19, true or false. If a patient presents for a sequela of an injury, the residual condition is coded first, followed by the injury code with the appropriate seventh character for sequela. Now I'm going to say this differently. This is the correct way to say it, but at AMCI we taught it a certain way. So that residual condition is coded first, and a residual condition is your sequela. And the injury code with the appropriate seventh character is your sequela code. Sequela is the sequel to the original injury. Just like a sequel to a movie, it comes after the original. It comes after the acute phase. So is this true or false? Does the residual condition, is that coded first for sequela, followed by the injury code with the appropriate seventh character? True or false? And if you don't know, I think we did a really good job on the first lecture explaining sequelas. I thought we did. So go back and look at that. Now I'm going to go ahead and give you the answer, and the answer is true. Now we're going to move on. All right, still in chapter 19, true or false. When a patient sustains multiple injuries, the guideline instructs the coder to sequence the injury most related to the chief reason for the encounter. And I want to add generally. When a patient sustains multiple injury, the guideline instructs the coders to sequence the injury most related to the chief reason for the encounter. Generally, true or false? Okay, Daisy, let's claim it. We're going to claim that you're going to be a coder. There you go. And I think you're telling someone because you're probably killing it in the chat. Yeah, I see you. Outstanding. I see you, Miss Beth. Thank you. All right, coders, is it true or false? Generally. All right, Janet, I'm going to stop with you, and the answer is true. All right, we're going to keep going. External cause codes are used to provide additional information about how an injury occurred, but are never used as the principal diagnosis. And that keyword is never. And the only thing that can supersede this, never, is a guideline. Is there a guideline that supports that? True or false? Okay. Okay. All right, I'm going to move a little faster, okay? Because we have some good things that we need to talk about, some good gems too. So the answer is true. Absolutely. And a guideline tells us that these external causes codes are never sequenced first. That's what I'm talking about. All right, true or false? We're now in chapter 20, external causes of morbidity. If documentation supports it, multiple external cause codes may be assigned to fully describe the cause, the place, and the activity related to an injury. True or false? What say you? Okay, those answers are coming in, coming in. Don't be afraid. It's true. Absolutely. Use as many Chapter 20 codes as necessary to describe the cause, place, and activity related to that injury. Now, we're going to switch gears and we're going to move on to Chapter 21, true or false. A Z code may be used as a first listed or principal diagnosis when it is the primary reason for the encounter. True or false? What say you? And the key word is maybe. And I'm going to move right along. Yeah. And that answer is true. Good job, good job, good job. I know you all are putting your answers in the chat, and I'm maybe kind of overlapping a little bit in terms of time, but good job, good job, good job. All right, we're still in chapter 21, true or false. History codes, such as personal history of malignant neoplasm, may be reported even when the condition is currently active. True or false? What say you? These answers are coming through. I see you, B. Frazier. I see you, Shinna, Zolma, Kathy, Francois. Okay, Daisy, I think you were DC Kicks. You guys were early. And the answer is false. False. So the key word is if the when the condition is currently active, you do not use personal history. Personal history means it's gone, it's history. Now, family history can still have the disease, but personal history has to be totally eradicated or removed from your body. All right, hopefully that was an aha moment. Good job, good job, good job. All right, Chapter 21, true or false? This is our last question. A screening code from Chapter 21 is assigned even if a condition is discovered during that screening encounter. True or false? Oh, no, this isn't the last question. Sorry. The answer is true. I think this is a trick question. It is. So it depends. It depends. If someone's getting screened for um, diabetes and they have diabetes, then diabetes is assigned. I think this is kind of iffy. It's both. Now, if the guideline tells you that you don't, then you don't. But sometimes you can't. You can because you have to code for the reason for the encounter. Sometimes. So it is true. It can be true. And finally, true or false. Codes from chapter 22, such as U07.1, may be assigned only when confirmed by provider documentation and it's not based solely on a positive laboratory result, unless the guideline permits. True or false? What say you? In other words, can the doctor just say this person has COVID-19? Do they have to have lab results to back it up? True or false? So, in other words, can the doctor just document COVID-19 to code it? True or false? Hi, Brenda. These are tough, aren't they? Okay, while you're getting those answers through, the answer is true. Absolutely. As long as the doctor documents it, this patient has it. And this is the same with HIV. The doctor can just say the patient has it, and it is fact. The guidelines tell you that. All right, so I got a little sidebar gem for you. If you have your MCG, the way to look up your guidelines, just open up your panel, your table of contents, scroll down, click on it, and the guidelines will populate. All right. Now, I want to review a few gems before we get started on our scenarios. All right, so for chapter 18, here is the gems. This is when you're coding for symptoms and signs, and there aren't any codes that you need to recognize. Just know that R00 through R99, running to the restroom, as a sign or symptom, right? Just know that's the code series. That's it. Yeah. Now, chapter 19, I don't have any particular codes that you need to remember. Just recognize that S00 through T88. So S00, this is where your injuries live. You're going to see your burns in the S category, your fractures, your adverse effects. Then, I don't know if adverse effects, I'm sorry, no. Adverse effects are in the T's, and your complications are in the T's. Okay, just know they live here. That's it. Chapter 20, this is your external causes of morbidity code series, V00 through Y99. Just know the code series. This is your vehicular accidents and things like that. So what the cause, the location, the place of service, not diseases. Diagnoses are not in this code series. Everything else, right? Now, chapter 21, we do have some codes that you should know on site. This is the factors influencing health status, and this is contact with health services. These are not diagnoses either. Look at Z00.00. This is the routine exam. That's not a diagnosis, right? Your encounter for chemo, we remember that from neoplasms. Long-term use of insulin, you should just know that on site. Know the family history know the personal history of code. Also, your single live birth and your single live born codes. Just know them on site because they have key guidelines associated, right? All right. Now we're moving on to chapter 22. Why do we even have this chapter 22? But this is the chapter for codes for special purposes. You're going to find codes like COVID-19 positive, U07.1. We know this is also in Chapter 1. Also, U09.9, this is post COVID disorders. You're going to, if you know it on site, it's going to be helpful. And this is basically the sequela. This is what happens to your body after COVID, right? So there are some post-COVID disorders that can be lifelong, and a lot of them are like heart problems and all different types of things. All right, so U07.0, this is vaping disorders, and you can find this also in the respiratory section. So if you know these on site, it's going to be helpful. And that's it. All right, so let's go ahead and let's look at some reviews. You all ready? Ready. All right. Of the following answers, which best describes the encounter? A. R07.1, B. I21.09, C. R07.9, I21.09, and D. R07.89. A 54-year-old patient presents to the ED with chest pain. After full workup, the provider documents acute myocardial infarction of the anterior wall. The pain is clearly linked to the infarction. Okay, coders, what's the answer? Don't look it up. Well, I do have the descriptors next to it. So A is for chest pain, unspecified. B is your STEMI, ST elevation myocardial infarction involving other coronary artery of the anterior wall. And C is chest pain, unspecified with the STEMI of the anterior wall. And D, that's your other chest pain. What say you? I see some people answering. That's what I'm talking about. And you know what? You could have a question like this on your exam. I could definitely see that. And you all are answering it like a pro. And I also want to tell you, people that say there are trick questions on the exam, I don't think there's any trick question. It might be a trick question if you don't know guidelines. You might think it's a trick question, but if you know guidelines, you just know this exam is a measurement of your guideline understanding. All right, I'm going to go. All right, so inventory. If this is your first time here, we inventory in the order presented. In other words, we write down keywords found in the documentation. Those keywords are diagnoses, signs and symptoms, treatment, and or procedures. So I go in order. All right, so this patient has chest pain. The provider documents an acute myocardial infarction of the anterior wall, and the doctor says the chest pain is related to the infarction. So I'm going to pull out the guideline, chapter 18, IC 18A, the use of symptom codes. Whenever you have a sign and symptom that's integral to a definitive diagnosis in your list, it should not be coded. And in this case, chest pain, and the doctor says chest pain is related to the AMI of the anterior wall. So we're going to get rid of all those chest pain codes. We're going to get rid of it at A, C, because they're sequencing chest pain with the AMI, and D. And the answer is B. Way to go, way to go, way to go. And I got a gem for you. And I just want to let you know that this guideline is so important to remember that they've placed it in 4 separate places in ICD-10-CM. It's under General Coding Guidelines. It's under Section 2. This is Inpatient Guidelines. It's under Section 4 Guidelines. This is Outpatient Guidelines. And we even have specific guidelines right in Chapter 18. So it's that important, and I believe it's something that you should commit to memory. That's right, Ms. Mills and Star Wars girls. This is a gem. It is. Commit that guideline to memory. All right, let's continue. Of the following answers, which best describes the encounter? A, N40.0, B, N40.1, C, N40.1, R35.0, R35.1, C, R35.0, R35.1. A 70-year-old male presents to the clinic with complaints of urinary friction frequency and nocturnal enuresis for the past several weeks. After evaluation, the provider documents benign prostatic hyperplasia or BPH. All right, coders, what say you? Is it A, benign prostatic hyperplasia without lower urinary tract symptoms, or B, benign prostatic hyperplasia with lower urinary tract symptoms, or C, frequency, nocturnal enuresis, and, oh, I'm sorry, I forgot, BPH with LUTS, and frequency and nocturnal enuresis, and D, frequency and nocturnal enuresis. What say you? Go ahead, put your answers in the chat. Okay, coders. Okay, it's a little mixture. We got some B's and we have some C's. Let's see. All right, so we're going to inventory. This patient complains of urinary frequency. They also have nocturnal enuresis, and the patient is diagnosed with benign prostatic hyperplasia. So if we just follow the guideline that we've just referenced, it says do not assign additional codes for associated signs and symptoms when identified with a combination code, right? So if we're following this guideline, we're not going to code urinary frequency or nocturnal enuresis. So we're going to get rid of C because it's coding for the those conditions along with BPH. And we're going to get rid of D because it's not even coding for the BPH. And urinary frequency and nocturnal enuresis are lower urinary tract symptoms. So the difference between A and B, A is without lower urinary tract and B is. So we would say, okay, based on this guideline, we would say, oh, B is the answer, right? Well, wrong. We learned something today. Instructional notes take precedence over all other guidelines. While we do normally, we don't code for related signs and symptoms, but we always should take a peek at the code to see if there is an instructional note, right? So let's go ahead and let's look up N40.1. And yes, underneath there are instructional notes. It says use additional code for associated symptoms when specified. So it says, sorry. It says if the patient has urinary frequency, R35.0, and nocturnal enuresis. Nocturia is nocturnal enuresis. So these two conditions are listed, and we should be coding them additionally with N40.1. So we're going to get rid of A because it's without lower urinary symptoms, and we're going to get rid of D because it's not coding for the BPH, and we're going to get rid of B because it is not coding for those lower urinary symptoms as told or ordered by the instructional note. So what do we do? What do we do? The answer is C. So we got a little gem. Instructional notes will always take precedence over all other guidelines. So always look up your first listed code, just to be sure. Unless if you know the code doesn't have instructional notes, then don't look it up. But if you don't know, take a look. And you know what, coders, I gotta say, this might be the only code that I've ever seen or I can remember. Now, instructors, if you know of any other codes that do this, and I'm sure there are, but this is the one that I remember. And again, if you don't know, always look up your first listed code. All right? All right, let's do another. And we're still in chapter 18. Of the following answers, which best describes the encounter? A. S06.1X0A, R40.2122, R40.2232, R40.2342, B, R40.212A, R40.212A, R40.223A, S06.1X0A, and C, S06.1X0A, R40.222, R40.2232, R40.2342, R40.2422, D, S06.101X0A, R40.212D, R40.223D, R40.234D. A 32-year-old patient is brought to the ED after a motor vehicle accident and is diagnosed with a traumatic cerebral edema. Upon arrival, the EMT documents a Glasgow coma scale with a score of eye opening 2, verbal response 3, and motor response 4. The emergency department confirms the same scores at presentation. Okay, coders, what say you? Okay, I gave you extra time. How many of you actually get intimidated when you see a lot of codes? Type in the chat. Let me know. I used to. I'm like, oh, there's a lot of codes. Then I started seeing a pattern. And I said, you know what? The longer they are, often the wronger they are. It means there's so many ways that I can see if something's wrong with it. Yeah. So I did I am going to instruct now in a way that'll help you kind of get over that fear. Hopefully it does. Let me know at the end. Okay? All right. So here is the inventory. This patient had a motor vehicle accident. They were diagnosed with traumatic cerebral edema, so they had some swelling. Upon arrival, the EMT took the Glasgow Coma scale. So they measured the eyes, and the eye had a score of 2. They measured the verbal response, that was 3, and the motor response was 4. So they do this Glasgow Coma scale to see the level of coma or consciousness you are, right? So what do? I'm going to go look up the coma scale guidelines, and there are a ton of them. And you're not going to remember all of them. You're not. But for the sake of this, we're going to go over them. They said you're going to sequence first your diagnosis. So basically, the diagnosis will go first. And second, your coma, right? Your coma scale codes, your R codes. Then your seventh character must match for all 3 codes. So these R codes, these coma codes, have to have the same seventh character. And all of them do. But look at D. Even though these all have the same seventh character, and D in this context means subsequent visit, A means acute, right? Initial treatment, that should match too. If you have an acute injury, your coma should also match. If this was the correct seventh character, and I'm thinking it isn't. Just saying. But anyway, I'm going to get rid of that. Now let's go ahead and let's continue. If you have multiple coma scores captured within the first 24 hours, you only assign the ones present on admission. So at the time the patient was admitted, and do not use these coma codes for medically induced coma, because that means the provider or the doctor put the patient in that comatose state, and it's controlled, so there's no need to measure. Also, do not use R40 with 2A. Now, these last 3, they pretty much aren't applicable. I'm going to hone in on these up here, and we're going to keep going. Let's go ahead and let's look up these codes. So I'm going to get rid of B because it's sequencing the R codes first. That guideline said, hey, sequence those R codes second. So those are going to be out of the way. And let's just take a look at the codes. You have S06.1XOA right here. I'm sorry. S06.1. Where's my point 1? I don't even think I have the right code up here. S06? I don't. Hmm. Hmm. I don't. So please forgive me. It's not here, but trust me, it is in this family, and it doesn't matter. Yeah, it doesn't matter. And the coma scale codes are here. They are classified according to, the eyes, the verbal, and the motor. So let's just hone in on these coma scale codes. All right. So we said the eyes score was a 2. The verbal was a 3, and the motor score was a 4. So these codes are all correct. They're all correct. But the only difference is C is coding this R40.2422. And this is for the total GS. GCS. It's the total score. So we know if you add up 2, 3, and 4, that's 9. So we would code this R40.242, right? Right? Let me look at this guideline. It says assign from the R40.24 if only the total score is documented. So the total score has to be documented, and it says it right here. So if the doctor didn't specifically, code out, say that this was 2, this was 3, this was 4, if the doctor just said, okay, the patient's GCS score is 9, then you would use this. That didn't happen. The doctor went ahead and, you know, carved out each one. So therefore, you do not need to code 240.24. Now let's take a look at these seventh characters. You notice they're not A and D, etc., right? If you look at your seventh character extender box, that's what I like to call it. 0 is unspecified time. 1 is in the field. So this is where the coma, the GSC, took place. Or 2 is the ED. 3 is in the hospital admission. And 4 is 24 hours or more after admission. Our circumstance is the ED department. So 2 is the appropriate seventh character extender. So we're going to get rid of C. And the answer is A. And I think, you don't have to know all guidelines, just some guidelines. Just know that these R codes aren't sequenced first, right? If we knew that, we can get rid of, B on site. We definitely got rid of D because it was coding for this A acute and also D subsequent. You can't do that. That didn't make sense. So we got rid of those two, and we just had to deal with the A and C. So the answer is A. And we got a gem. And the gem is there are I think this is a lot to remember. So just know there are coma scale guidelines and make sure you reference. And that's it. Everybody good? We got 2 minutes. 2 minutes. If you have to excuse yourself, go ahead. I'm going to keep going. I might be here about 15 more minutes. Of the following answers, which best describes the encounter? A. S72.301A, B. M96.661, C. T84.040A, D. S72.301A, Y65.8. And Mr. Sandeep or anyone, if you could put in the chat the survey, please let us know how the first 8 weeks went. It's not a big survey. So please, that's all we're asking. Fill out the survey. That's it for this free course. Complete that survey. Oh, yeah. And like up this video if you like it. Okay, a 74-year-old patient undergoes a total hip arthroplasty. During the procedure, the surgeon documents an intraoperative fracture of the right femur caused by surgical manipulation. OMG. Thank you, Mr. Sandeep. Okay, coders, what say you? Is it A, unspecified fracture of the shaft of right femur, initial encounter? B, is it fracture of bone following insertion of orthopedic implant, joint prosthesis, or bone plate right femur? Is it D, mechanical loosening of internal right hip prosthetic joint, initial encounter? Or D, femur fracture, other specified misadventures during surgical care? What say you? Okay, I'm going to move right along. A lot of you said B. I understand. You are putting your answers through the chat. Doesn't mean it's correct. I see D. I see B. I see D. All right, so here's my inventory. This patient had a total hip arthroplasty. That's a hip replacement. And during the surgery, this patient had an intraoperative fracture. So the doctor was manipulating that area and boom, fractured the patient's hip. So there is a guideline. We have iatrogenic or genic, iatrogenic injury. That means that that injury was caused by that provider from medical intervention, right? And when that happens, do not code it as an acute injury. It's not. It's not a commute. It's acute injury, and you need to code the complication. You need to code what that injury is specifically. Doesn't mean you need to use a complication code, that injury, that complication. All right, so if you do not code acute injuries, we're going to get rid of the acute codes, right? At A, you see S72 and D, S72 category. Those are for acute injuries. So they got to go. Got to go, got to go, got to go. Now that leaves us with B and C. Now this T84.04A, this is mechanical loosening of internal right hip prosthetic joint. Did that happen? Was there a mechanical loosening? Absolutely not. No, this patient's bone was fractured due to manipulation as they were carrying out that hip replacement, right? So if you look at B, this is fracture of bone following insertion of orthopedic implant. That is basically a hip replacement. They're putting in an implant. They are removing the joint and putting in a new joint, a prosthesis, a prosthetic joint, a prosthetic hip. So C is wrong. D describes your what happened best, and the answer is B. And here is your gem. Iatrogenic means intraoperative accident or injury, and complication does not necessarily mean use a complication code. You're just supposed to code that problem. Are you all with us? Thank you, Brenda. All right, Shanna. All right, all right, all right. Let's go. All right, so it's 104. I'm going to keep going. All right. Of the following answers, which best describes the encounter? A, S72.351B, S52501B, C, S72.351A, S52.501B, and S52.501B, and S572.351A. A 29-year-old patient is brought to the ED after a motorcycle accident. Image Imaging reveals a closed, displaced, comminuted fracture of the shaft of the right femur and an open, non-displaced fracture of the right distal radius. Both fractures are initial encounters. Okay, coders, what say you? Go ahead, put your answers in the chat. Okay, I'm going to continue. So go ahead, feel free to put your answers in the chat. And you know what I want? I want you to tell me what your if you don't know right away, just what your gut says. I want to see those gut answers. All right. So my inventory, this patient's in the ED. They had a motor vehicle accident. In the event that we would code those chapter 20 codes, closed, displaced, comminuted, fracture of the shaft of femur, the right femur, and we have an open, non-displaced fracture of the distal radius, the wrist, right? So, if we're looking at our guidelines, this closed displaced fracture of the shaft of right femur is the thigh, right? And the open displaced fracture of the distal radius, that's your wrist, right? So we need to sequence the most complex over the least complex, right? Because if we look at our sequencing here, you're going to sequence your most complex, you're going to sequence the second first and then followed by the least complex. So we need to know which one is more complex, that femur or the wrist. Which one was most complex? Well, your key word is open. That's an open fracture. Open fractures are often most complex than a closed. Not always, but often, right? So we're going to go ahead and we're going to look at our seventh character extender box. And in this section, in the fracture section, those seventh character extender boxes are different. So you got to lock in and pay attention to the seventh character extender. So A is the initial encounter for a closed fracture. So that should be on the femur code. And B is the initial encounter for an open fracture. And that should be on the wrist code, right? So it's going to be A for the femur, and it's going to be B for the wrist because it's open. And let's go ahead and lock in on our answers. So we know that open fractures generally are going to be more complex. So B should be sequenced before A. The B seventh character should be sequenced before the A. So we're going to get rid of A because it's not even sequencing the other condition. We're going to get rid of C because it's sequencing the A first before the B, the closed before the open. So we're going to get rid of those two. And we're also going to get rid of B. You see how clear things get when you eliminate some things? They're distractions. So now I can lock in. Look at B. B's not even coding for the A procedure. It's not even coding for the femur. So we're going to get rid of that. And the answer is D. The answer is D. So the gem is when you're coding fractures, begin with open or closed. If you have multiple fractures, if you got the open one, when you're taking the exam, that open one is going to be more complex. So if you got that correct, or if you learned something, that is priceless. All right, so I was going to show you, just kind of look at the seventh character box, but we don't really have time, and we have another scenario. So let's go ahead and let's do it. Of the following answers, which best describes the encounter? Now we're moving on. We're no longer talking about fractures. We're in the poisonings and um, what is that called? Adverse effects. Okay. All right. A, T46.4X1A, T78.3XX. B, T78.3XX, T46.4X5A, and C, T78.3XX, and D, T46.4X5A. Coders, I'm going to tell you, I can answer this question without the code descriptors, and I'm going to show you how I do it. A 65-year-old patient is prescribed lisinopril for hypertension and takes medication exactly as directed. 2 days later, the patient develops angioedema and the provider documents angioedema due to adverse effect of lisinopril. Okay, coders, how I do it, this is the only guideline that I remember. So when you're coding poisonings and so forth and adverse effects, I only remember the adverse effects guideline. That's it. So there are a few things, about three things that I remember about it. And one of the things I remember is in order to code adverse effects, it has to be properly prescribed and properly taken. Right up in here, properly prescribed and properly taken. It's saying that. And then I read everything else. And you know what? I can choose the code off the bat, and I'm going to show you. All right, so I talked enough. We're going to go ahead and I'm going to show you my inventory. Patient was prescribed lisinopril and it was taken as directed. The doctor says the patient develops angioedema, and the doctor diagnoses the patient with angioedema due to adverse effect of lisinopril. So I'm going to get rid of this angioedema because it's integral to number 3, and I'm going to go look up the guideline. And the guideline is the guideline for adverse effects. And essentially, it said that this drug has to be correctly prescribed. If it wasn't prescribed, coders, it's poison. If it wasn't prescribed, coders, it's poison. If it's over the counter, it wasn't prescribed, it's poison. So anything that's not an adverse effect is a poison. Just saying. All right, so the guideline basically says that. And then when you are coding, you've established it's an adverse effect, you're going to have to code it as following. Number 1, you code your adverse effect. You code that condition. Number 2, you sequence your T code in that order. All right, coders. So we can eliminate C and D on site because we need 2 codes. You got to have 2 codes to code an adverse effect, right? That condition and that T code. The T code includes the medication as well as the adverse effect, what happened. So the answer is going to be B. The answer is B. And this is why. Down here, after the sequencing, your 5th or 6th character is always 5. Adverse effect codes always have a 5 at the 5th and 6th level. I know that. I'm always looking for that 5. So before anything happened, it had to be either B or D. But I know the guidelines. I know I have to code that condition first, followed by your T code, your adverse effect code. Okay? So the answer is B. And my gem, I got a few, know how to sequence adverse effects. Your condition is first, followed by your adverse effect of medication code, your T code. Now lock in. This is how you do it. Whenever you have these scenarios, lock in on identifying the adverse effect. Look for the prescription. If it's not prescribed, it's a poison. You got to have a proper prescription and it has to be properly taken. And another thing, you can recognize adverse effect codes, those T codes, when the 5th or 6th character is a 5. These other ones, these are looking like poison codes. That's your poison code, poison. That's one poison, and this is your, the lisinopril, the angioedema due to. All right. So hopefully that says everything. Now we've gone way over, and I'll do this one. I'll do this one, and then we're going to be finished. I just can't help it, coders. If you need to go, go ahead. I thank you. virtual hugs to you. Please, Mr. Sandeep, if you can drop the survey, please fill out that survey. Please like this up if we've done what we need to do. Of the following answers, which best describes the encounter? A. W11 XXXA S82.202A, B, S82.202A, W11.XXA, C, Y92.009, S82.202A, W11.XXXA, and D, W11.XXXA, Y92.009, S82.202A. If you know your guidelines, you can answer this question off bat right now. A 22-year-old patient presents to the ED after falling from a ladder while painting his house. The provider documents a displaced fracture of the shaft of the left tibia. The fall occurred at the patient's single family home. All right, I'm going to walk you through it. My inventory. Patient fell off a ladder, sustained a displaced fracture of the shaft of the left tibia, and it occurred at a single family home. If you know the guidelines, Chapter 20 says Chapter 20 codes are not sequenced first and they are never stand alone. That's right. That's right. They're never sequenced first. So look at A. And we also know that this Chapter 20 series, Chapter 20 code series for external causes of morbidity is V00 through Y99. So any code within that code series applies. So if we're looking at A, that's incorrect because we're sequencing this Chapter 20 code first. C is we're sequencing the Chapter 20 code, that place of occurrence, first, and D as well. So the answer could only be B. And no one fooled you all. Everybody that answered said B. Way to go, way to go, way to go. So just remember, external causes codes are always sequenced first after the first listed code. They're always sequenced after the first listed code. And yes, always, because it's a guideline, a guideline. And I do have Chapter 21 codes. We're going to let those go. And let's see. So I just want to just go ahead and end things. And I just want to say that if you got one thing correct, that's outstanding. However, if you learned something, I don't care if you didn't get anything right, but as long as you learned something, that's priceless. It's forever. And my final word, you need to complete. Why am I talking about week 8? No, week 9. You need to complete everything in week 9. Okay? So go to your syllabus, go to week 9, complete everything by next week. Yes, we are going to talk about HICPICS level 2. We're going to talk about another code set. We're finished with ICD-10-CM, but ICD-10-CM is going to continue. So go ahead and attend the Monday guideline class if you want to review. Miss Haley will be there. Miss Haley, I'm not sure you're going to be there this week. Let me know. I don't know if she is. All right. But anyway, if you have access to our Quizlet, go ahead and use chapters 19 through 22. Never use an encoder. Remember that. Never use blind process of elimination. Never. Always rely on your guidelines and your tools, because it's going to make you a stronger coder. And remember, 2026 guidelines will always take precedence. If you intend to buy the AAPC Practicode, remember, take that Practicode after you've passed your medical coding exam. And on that note, I'm going to say thank you to my team. Thank you, Mr. Sandeep. Thank you, Miss Haley, Ms. Mills. Thank you, Miss Beth, Miss Leslie. I don't want to miss anybody, but you all knocked it out in that chat. And thank you, coders. You all show up, show out every week. And I just couldn't be more proud of what I see. And somebody, Daisy said she didn't even have the books and she was up here doing these scenarios. That's what I'm talking about. That's what I'm talking about. All right, so yeah, we have a small break this week. Thank you, Ms. Haley. Small break this week. There will be no ICD 10 but we start back the following week, and we're going to start back from week 1. We're going to keep going. All right, so we'll see you next time. Thank you, and have a wonderful weekend.
4,000 exam passers and free classes at AMCI. Learn to go straight from home or on the road at AMCI. We're on the East Coast, the West Coast. We're all around.